Hi everyone, it's Dr. Ryan here. Today we're going to delve into part 2 of the top 8 concerns that patients enrolled in LeanFast, my customized medication-assisted weight management program, have about semaglutide. Today we're going to focus on thyroid cancer risk, pancreatitis risk, risk of kidney damage, and the concern for weight regain after starting semaglutide. We'll look at the science behind these concerns and what current research tells us. The first thing that we're going to address is the risk for thyroid cancer. Animal studies have suggested that there is a potential risk. These were rodent studies involving semaglutide at larger doses, and that can understandably raise alarms. However, it's crucial to note that human studies have not found a direct link between semaglutide and thyroid cancer. Moreover, research indicates that semaglutide may actually restore the function of anti-cancer cells in individuals with obesity. This suggests a potential protective effect, although further research is needed to confirm these findings. So this article in the International Journal of Molecular Science was, as the article implies, a literature review in which they looked through did a systemic search of PubMed, Scopus, and Embase databases involving 10 randomized controlled trials with over 15 or close to 15,000 participants, of which about 7,800 received semaglutide. And what they found after doing a large-scale study was that the incidence of thyroid cancer in semaglutide-treated patients was less than 1%, which, according to the authors, suggests not a very significant risk at all. And now, let's talk a little bit about another article that may suggest semaglutide could have protective effects in cancer. This was titled, Glucagon-like Peptide-1 Therapy in People with Obesity Restores Natural Killer Cell Metabolism and Effector Function. And so basically, what the authors here suggested is that semaglutide seems to increase natural killer cells. Natural killer cells are a type of white blood cells that work against pathogens as well as abnormal cells like cancer cells, and they do so by producing cytokines, which are basically proteins, inflammatory proteins that help target these particular cells. And what they found is they looked at 20 people, they called them PWO, people with obesity, that were on semaglutide. And they had been on it for about 6 months, and they wanted to see if it improved their natural killer cell function. And what they found was that it did. It seemed to improve their function. They measured it by the ability for the natural killer cells to kill other cells, cytotoxicity, as well as release these cytokines, interferon gamma and granzyme B production, and found that they were increased. And so, whereas this doesn't necessarily mean that semaglutide can prevent cancer, it does mean it can seem to improve the metabolism and the function of these natural killer cells, which could be quite promising for maybe using this in the future as an adjunct in cancer therapies, potentially. Okay, so the next thing that we wanted to address was pancreatitis. So pancreatitis, or serous inflammation of the pancreas, is something that is a big concern for many patients. It is something that has been reported with semaglutide. One key recommendation that I would mention is to avoid alcohol while taking semaglutide, as alcohol consumption can certainly increase your risk. However, the studies have shown that typically, when guidelines are followed, alcohol consumption is decreased, in particular, in following a healthier diet reduced in fat, the risk is considerably lower than people think. Now, this article in the Journal of Endocrinology, Diabetes, and Nutrition, titled Acute Pancreatitis Due to Different Semaglutide Regimens, an Updated Meta-Analysis. What they did was they basically did a meta-analysis, so they did a large analysis of many randomized placebo-controlled studies of semaglutide therapy and looked for reports of acute pancreatitis. So they looked at 21 eligible trials of semaglutide, which included 34,000 patients. And what they found is that semaglutide was not associated with an increased risk of pancreatitis. It appeared that this really did not make a huge change whether or not the group used oral semaglutide, low subcutaneous doses of semaglutide, or groups with high subcutaneous doses of semaglutide. Conclusion that these authors had is that it really is not associated with the increased risk of pancreatitis. That being said, there have been reports of pancreatitis in patients taking semaglutide. So here's a case report of an individual who developed pancreatitis when she was taking semaglutide. And this particular individual is a 61-year-old female. She had a medical history significant for diabetes, high blood pressure, depression, and obesity. And she was on a couple of different medications, metformin, zolpidem, lisinopril, and atorvastatin. And she definitely developed a lot of the symptoms of pancreatitis after starting semaglutide 2 months earlier, and she was doing once weekly dosing. And it was determined primarily by an elevated lipase level. This is an enzyme that kind of rises when patients develop pancreatitis. Now, of note, she did not have a history of alcohol use. In fact, she denied drinking. However, she had diabetes, and diabetes, as the article indicates, does have a 74% increased risk of acute pancreatitis. And then something that's somewhat unusual is that one of the medications that she was on, atorvastatin, also does that too. If you look at this article here, atorvastatin-induced pancreatitis from the Indian Journal of Pharmacology, this was actually a case report of a 58-year-old male who was prescribed atorvastatin 10 milligrams for hyperlipidemia and developed pancreatitis. Semaglutide probably is not linked to pancreatitis. I would definitely curtail alcohol consumption while you're on the medication. And then also realize if you do have diabetes and you are taking a statin, that might increase your risk as well. So the key thing is, if there's a way to reverse your diabetes, which is quite possible through diet. I've done that for a lot of my patients. I've been able to get patients' hemoglobin A1Cs from like 6.7, 6.5 down to 5 through diet and exercise regimens, including semaglutide. That would be one thing. And then come off the statins, which is also quite possible through dietary changes. That would be recommended. Now, the next thing that patients are concerned about are kidney problems. There's a concern that semaglutide might cause or worsen kidney issues. However, current research suggests that semaglutide actually has kidney protective effects. In fact, it's been shown to improve the urine albumin to creatinine ratio in certain patients, which indicates a beneficial impact on kidney function. Before we get into this, let's first talk about what urine albumin to creatinine ratio is. Well, urine albumin to creatinine ratio basically is a measure of kidney function. So albumin is a protein in our blood that's very important for transport of hormones and micronutrients and other proteins within your blood. And it also is really important for ensuring that fluid is pulled out from the periphery. So if you don't have enough albumin, sometimes you can be at risk for edema. And the kidneys, one of the main jobs is to filter the blood, right? And if your kidneys aren't functioning appropriately, a lot of albumin can spill out into the urine rather than being reabsorbed. And we can test this by checking your urine, measuring the amount of albumin in the urine, and then assessing a score called the urine albumin to creatinine ratio. And generally, if it's less than 30 milligrams per gram, it is normally to just mildly increase, but if it's greater, 30 to 299, it's moderately increased, and if it's greater than 300, that's a pretty big deal. So this is a pretty good marker for assessing kidney function. And what this article suggested here is that semaglutide may improve this. So this particular article, it basically looked at a cohort of patients that received once weekly subcutaneous semaglutide at 2.4 milligrams or had a placebo for 68 weeks, and they measured urine albumin to creatinine ratios, right? And these individuals had type 2 diabetes, so they were already at risk for kidney dysfunction. And what they found was that at week 68, after they were on the semaglutide for about 68 weeks, urine albumin creatinine ratio changes were, they had dropped 14.8% and 20.6% in the 1.0 and 2.4 milligram dosing respectively, and increased 18.3% in the placebo group. That is a group that was not taking semaglutide. So essentially, the conclusion was that semaglutide really did improve their urine albumin to creatinine ratio and is likely kidney protective. Okay, so the last concern that patients have is weight regain. So let's talk about that for a little bit. This is a really common concern among patients. Patients will come to me and say, "Hey, Dr. Ryan, well, if I get on semaglutide, is this something I have to stay on forever? If I come off, will I regain all my weight?" Right? And there have been a couple of research studies that have looked at this. So this article in the Journal of Diabetes, Obesity, and Metabolism, titled Weight Regain and Cardiometabolic Effects After Withdrawal of Semaglutide, looked at a group of individuals that were randomized to either receiving semaglutide or not at 2.4 milligrams a week, and and they were treated for about 68 weeks. And after 68 weeks, they were followed for a further 1 year. And what they found was that the individuals following treatment withdrawal, the semaglutide and the placebo participants did regain some weight. So the semaglutide patients did regain 11.6 percentage points of lost weight, whereas the placebo participants gained 1.9 percentage points of lost weight. And so the net loss for both of them was 5.6% in the semaglutide group and 0.1% in the control group. So in other words, there was definitely some weight gain in the individuals that were on semaglutide that came off, right? In fact, it did seem that these participants regained 2/3 of their prior weight loss. Now, one thing that I want to emphasize is this. I have not seen this with my patient group. When patients come in to Lean Fast, we put them on a pretty structured diet and training program that allows them to understand the best way to eat. So they're typically following diets that are higher in leaner protein, utilizing carbohydrates that are less processed, using healthier fats, and engaging in an exercise program that is easy for them to follow on their schedule. And when they maintain these habits, which are fairly easy, they're able to maintain the weight loss. Another thing that I do, unlike the article, is when I'm putting patients on semaglutide, I use lower doses, right? And then when it's time to titrate off, we do it in a fairly slow fashion. If, for example, they might be on 0.5 milligrams a week or maybe 1 milligram a week, when it's time to come off or they would like to transition off semaglutide, we'll start with perhaps, if they're at 1 milligram, we'll start with 0.75 milligrams a week and do that for a couple of weeks and down to 0.5 and then finally down to 0.25 and then they'll come off. And when we do a slow reduction where they titrate off semaglutide, it really does seem to allow them to continue weight loss. Remember, it is quite possible to maintain weight loss if you engage in healthier habits. If you're eating less, if you're working out, if you're eating the appropriate foods, you will lose the weight. And then the last thing I do want to mention is that there is a contingent of patients that are on semaglutide long-term because of its potential longevity benefits. There's data suggesting semaglutide can reduce vascular inflammation, improve autophagy, reduce atherosclerosis. So whereas you don't have to be on semaglutide long-term, there's a lot of people in longevity space that think that at a low dose, maybe 0.25 or so a week, would be a good idea. So that's something to think about as well.